Start now. Good morning, respected seniors, colleagues. Today we are going to present a case of 33-year-old male from Sarlai who presented in 2023 at Chitwan Hospital with complaints of pain, abdomen, and vomiting. The initial CT scan findings showed large, well-defined, heterogeneously enhancing retroperitoneal mass measuring 138 by 105 millimeter, and it was conglomerated with multiple celiac and aorticable lymphadenopathies encasing the abdominal aorta and left renal vessels. The biopsy of the retroperitoneal mass, two-cut biopsy, was suggestive of poorly differentiated carcinoma, and immunohistochemistry was advised. On immunohistochemistry panel, the panel was suggestive of non-seminomatous germ cell tumor, yolk sac tumor, and the IST markers that were positive were SALL4, cytokeratin, GPC3, and it was suggestive of yolk sac tumor. The baseline tumor markers in 2023 showed significantly raised AFP of 827 nanogram per ml and raised beta HCG of 41.23 milliliter national unit per ml. The CT scan was again repeated after a few cycles of chemotherapy, and the CT scan done on May 2023 revealed multiple enlarged retroperitoneal lymph nodes and with mesenteric lymph node near SMA, which showed necrotic foci, and there were areas of calcification inside the lymph node. The largest lymph node measured 3 by 5 centimeters, and one of the enlarged lymph node was aborting third part of duodenum and proximal jejunum, and there was lots of fat playing with the jejunum, and with few air foci seen inside the lymph node. The treatment was started at Chitwan Hospital. The patient received 3 cycles of EP regimen, and the first cycle was started on 15 March 2023. Later, the patient was again admitted at BPK MCS Hospital, and he received 7 cycles of BEP regimen, bleomycin, etoposide, and cisplatin. And patient received initial cycles of chemotherapy, and after that, the AFP and beta HCG dropped to normal levels, and the current status is that after receiving 7 cycles of chemotherapy, patient defaulted from follow-up. Although the patient was called for follow-up, he did not come back due to financial constraints and personal reasons for 3 years. Now, the patient again came back after 3 years with chief complaint of right upper quadrant abdominal pain for 10 days, yellowish discoloration of eyes for 8 days, and fever of 4 days duration. His recorded temperature were 100 Fahrenheit to 102 Fahrenheit. As the blood pressure, pulse, SpO2 were within normal limit. On palpation, there was absence of any mass in the testis. Lab reports showed leukocytosis 29,700. WBC count. Total bilirubin was 6.6, direct was 4.8, and ALP was raised. The tumor markers were repeated this time also, and the beta HCG and AFP both were normal. And the recent imaging showed was suggestive of hypoechoic collection in the right lobe of liver, consistent with liver abscess, and the CT scan was again done on 1st August, and this is the CT scan of the patient, and it shows cystic lesion in the segment 7 and 8 of the right lobe of the liver. And a fecal catheterization of the liver abscess was planned. Initially, there was no pleural effusion seen in the lungs, but after repeating the chest X-ray, after a few days, we could see the collection in the right pleural space. So pictal insertion and chest tube drainage, chest tube insertion both were done. Chest tube was inserted on the right pleural space. And the post culture and sensitivity showed no growth after 24 hours of incubation, and the post cytopathology revealed absence of malignancy or atypical cells. So this was the case. The Spanish Medical Oncological Society has published an uh, article where the management of the relapse cases. They have said that the management of the relapse cases should be done by multidisciplinary team in experienced centers, and the salvage treatment of these patients includes conventional dose chemotherapy with paclitaxel, ifosfamide, and cisplatin, and or high dose chemotherapy. Although the best regimen and the strategy for each for each time such uh, cases is not clearly well established. Uh, in late recurrences, early complete surgical resections should be performed when feasible. Okay. They have said that uh, in cases of recurrence after chemotherapy, the mass should be resected. And there is another study where they have advised patients with retroperitoneal non-seminomatous Johnson tumors should be treated according to IGCCC risk classification. And if the risk is good, the patient should receive the 3 cycles of BEP, and in case of intermediate risk, the 4 cycles of BEP, and in case of poor risk, also 4 cycles. And the alternative regimen has also been described. And the response of the evaluation of the response of the treatment is observed by monitoring the levels of AFP and CT scans of chest abdomens. Uh, and if in the follow-up, if AFP normalizes, but there is structural mass remaining, then the mass should be resected. If AFP level stops dropping or starts rising, it indicates resistance to chemotherapy or early relapse, and we may need to change the chemotherapy to second line high dose chemotherapy. All residual masses of non-seminomatous yolk sac tumor must be surgically resected, regardless of how small they are. And retroperitoneal lymph node dissection is also advised to clean out the retroperitoneum. And there was a study from China and of a 19-year-old female with large solid cystic mass located in the retroperitoneum. The tumor size was large and widespread metastasis was identified during exploratory laparotomy. The postoperative histopathology revealed yolk sac tumor. The patient underwent 3 surgical procedures and 17 cycles of chemotherapy of different regimens. And the patient had recurrence in the liver and spleen 21 months after the diagnosis. Yolk sac tumor may relapse following surgical treatment. However, surgical resection is currently the optimal treatment method. In this case, bleomycin etoposide and cisplatin, and another regimen of bleomycin, vincristine and cisplatin, and another regimen of vincristine and cisplatin chemotherapy regimens were given to the patient, which were effective. Uh, and alpha-fetoprotein is an important tumor marker for monitoring the yolk sac tumor recurrence, and observation of raised AFP levels during chemotherapy indicates poor prognosis. And some of the studies have, one of the studies done in Canada has shown that there is a burnout phenomena where the after the chemotherapy, after the treatment of the gonadal yolk sac tumor from the testis, although in the follow-up there may not be any growth palpable in the testis, it may present with metastasis in some other organs. And unless proven otherwise, every germ cell tumor located in mediastinum or retroperitoneum or other locations should be treated as primary tumor of the uh, uh, testis. But this study included very less number of patients, and there are not many randomized controlled trials and systemic reviews of this case.
Yeah. Well, thank you, Dr. Sagun. So there are various questions to this patient. First of all, we don't have a complete database of this patient because all the CT scans, what was the prime, it was noted the retroperitoneum are missing. We don't have the CT findings initially. So my few questions, few queries, then we can come to the discussion. First would be your Sandeep minus Southern Lebanon important you just replicate this from the retroperitoneum, just think that is from media style from your point of view. Similar things may have been in the media style. So first, how do you classify the germ cell tumors? This is the case of germ cell tumor. You mentioned throughout your slide several things, but in general, if somebody asks you, how will you make an entity? How will you, how will you put a diagnosis, final diagnosis of this case?
Classification includes gonadal and extragonadal, and in gonadal and further into the classification, there are seminomatous and non-seminomatous germ cell tumor, and in seminomatous germ cell tumors, it includes seminoma, and in females, dysgerminoma. In the case of non-seminomatous germ cell tumor, there are four types: teratoma, yolk sac tumor, choriocarcinoma, and um, embryonal carcinoma.
So, just for Dr. Sajid, he's our medical oncologist. He has just joined us. So he's a 37-year-old patient. Summary: 3 years ago, he came with retroperitoneal mass. Testes were normal. He had a huge mass, about 13 into 14 centimeter in the retroperitoneal. The true-cut biopsy showed poorly differentiated carcinoma. Then the ISU which showed the yolk sac tumor, and the alpha-fetoprotein was markedly raised. So we was diagnosed, I think, perhaps with the stage 3C retroperitoneal yolk sac tumor, because there were multiple lymph nodes which were not excisable. So patient received EP regimes for 3 cycles, followed by 7 cycles of BEP regime. In total, he received 10 cycles of the chemotherapy. There was some response in between when the reassessment was done in between the chemotherapy. The calcification was there, and the retroperitoneal mass was also decreased in size. After that, in this 3 years of period, I mean in 2.5 years, I would say, patient disappeared because of the financial constraints. Now he comes with fever for 2 weeks of time with right hypochondrial pain and mild icterus. Bilirubin was 6 or something. He had leukocytosis of more than 25,000. And in the CT scan, there was a huge mass in the liver, cystic mass in the liver with thick walls. There was nothing in the retroperitoneal. So, and alpha-fetoprotein beta ICG LPS were in normal level. So, he was suspected to have the pyogenic liver abscess. On aspiration, he showed the was The culture was negative, site was negative. Then we planned for the pictorial drainage. We were thinking something, maybe it is the component of the germ cell tumor itself relapse, but since it was purulent material, we thought it is simply the liver abscess. So pictorial drainage was planned, but at the same time, patient developed shortness of breath and cough. Chest X-ray showed, which was not initially present, showed the pneumothorax. So we suspect the the lesion has ruptured in the chest cavity. So we inserted both the picture inside the liver cavity, which did not yield anything, much than 40 or 50 ml of secretion. But from the chest tube, the pus collection air was evacuated. And later, the drainage from the chest drain is bilious. Now it's bilious in content, right? It's coming 200, 300 ml per day. Patient is symptomatically better. He doesn't have fever. He doesn't have shortness of breath. So this is the situation of the patient. So now we're just discussing this. Recently we started the discussion about the same patient. So first question was regarding, so we have the yolk sac tumor, that's culprit. So is there a probability of relapse of the germ cell tumor? What do you think? Since we do not have the CT film, so far we are thinking the initial presentation was in the retroperitoneum rather than the liver. Maybe the radiologist missed it. Could have been primarily from the liver, but they interpreted it as a retroperitoneal mass. This could be because we don't have the CT film, so I suspect. So do you think, so this is the recurrent germ cell tumor? Let's suppose the scenario that is primary was there in the liver, the same place. If we visualize the similar picture beforehand, maybe similar method. We don't know exactly. Do you think, let's suppose same location must have that will make more interesting for the discussion, I think. What do you think? Is this a relapse?
This may be relapse.
If relapse, why the AFP beta is normal?
That suggests otherwise.
So it goes not against the relapse, but is there some entity? Because the patient has been missed since last 3 years. We don't know the status 6 months before. We don't know the status 1 year ago. So Mahesh, what do you think something else? He has made one point in his slide. He didn't write clearly, but he said despite the alpha fetoprotein tumor markers normal, there could be the increased size of the lesion, which requires surgery, right? You have mentioned in one of your points. So what does it mean? Markers are normal. He has the larger diameter in liver mass, which was before only 8 centimeter. Now it's 13 centimeter. But the markers are normal, tumor markers. So what do you think? के हुन सक्छ सन्दीपले के भन्छ यो क्वेशन आउँछ सिमिलर मेडियास्टिनामा ठ्याक्कै रेप्लिकेट गरेको दिस कुड बी द ग्रोइङ टेराटोमा सिन्ड्रोम because we don't have any other हुन सक्छ now the question comes if the growing teratoma syndrome if there is the tumor could it be only cystic I'm really confused whereas in the liver abscess or cystic could it be cystic
It is an
important two question. I couldn't be purely cystic like in this case. You don't know exactly, but maybe cystic. But yes, it has been described like mature cystic teratoma. They have got the mixed components, solid and cystic both. In few situations, rare cases, they could be purely cystic also. So we cannot totally deny this is not the growing teratoma syndrome. So one probability, I'm not necessarily सोच्न सक्छौ एउटा. Now second question comes. त्यो त सर्जरी स्ट्रेट फरवर्ड हुन्छ त्यो भनि नि हाल्यो ठीक छ. So relapse could be a possibility. Okay. Sagulले के भने जो बारम्बार भने एउटा Canadian study उनले कोट गरेको थियो his testes were normal now so is normal. How will you evaluate the testes? Testis evaluation गर्ने एकदम must work. जरुरी how are you going to evaluate the testes? Clinically only?
Evaluation with ultrasonography.
Ultrasonography is the best by virtue of which you can evaluate the testis whether there is something or not. Indeed, you have to exclude. If the testis is the primary, would it have changed the approach initially? Testis को primary से retroperitoneal liver में आयो. Would you have done differently rather than going for the chemotherapy up front?
So the management would have been the same.
No. Nice. Same thing, testis primary देखियो mediastinal lesions. Would it have changed your approach? Would you consider for the chemotherapy first?
Chemotherapy is the important thing.
No, first you do the orchidectomy. जहिले पनि टेस्टिसको प्राइमेरी देखिया छ भने फर्स्ट यु द वर्टिडक्टिभ फलोड बाई के हुँदाखेरि सधैँ सो फर्स्ट याद राख्ने जेमा पनि टेस्टिस चाहिँ निकाल्नै पर्छ यो भन्छ बट सिन्स ही डजन्ट ह्याभ द टेस्टिकल रिलिजन्स सो नाउ वुड यु कन्सिडर फर द वर्टिडक्टोमी बाइलेटरल सिङ्किङ द एटिट्युड फ्रम द टेस्टिस रिकमेन्ड हुन्छ He said that there is a rare possibility that there is a regrowth phenomenon होइन पहिला केही पनि थिएन भविष्यमा आउन सक्छ भने so on that database can you consider for the prophylactic orchidectomy it's not recommended the flat answer is we don't know what is happening in the future त्यही भएर हामी त्यतातिर जाँदैनौँ my question is मैले साधनसँग पनि मलाई थाहा नभएको हुन्छ he said 3 cycles of EP regime my first question would be for retroperitoneal location of the tumor. For your concern and the germ cell tumor, non-seminal matters common is with the testis. Second is retroperitoneal. Third is the mediastinum. Then the sacral coccygeum, etc. Any other organs. So the second site of the extragonadal, the first site of the extragonadal, over the second site of the non-seminal matters. So would you recommend 3 cycles of EP regimen in this location, or would you consider some another chemotherapy regimen?
What is the age of the patient, sir?
37.
37. I guess he has completed the family and he has no any pulmonary issue. Then we can go for EP regimen, sir. In case of retroperitoneal.
The retroperitoneal. So I think the question is very clear. So BEP regimen would have been better even for the mediastinum, not only for the retroperitoneal. Now he completed 3 cycles of chemo. He kept on receiving 7 more cycles of BEP regime. What is the maximum number of chemotherapy BEP that you provide?
4 to 6 cycles.
4 to 6 cycles. Generally 4 cycles. When they have 4 cycles, then if the patient doesn't respond, then
we should go for second line.
Second line. So the patient kept on receiving 10 cycles of first 3 DP followed by 7 cycles of BEP regimen. So I think we should reconsider. Sometimes there could be some scenarios. Now, why the pyonemothorax happened in this case? अब यो केसको बारेमा यो त जनरल हाम्रो रेफरेन्स भयो what do you think why the pyonemothorax day before the insertion just one day before there was no pyonemothorax now suddenly pyonemothorax happens
the abscess in the liver right lobe was very large and it was close to the diaphragm. It perforated into the pleural space.
So what would be your message to the MS residents when they see such kind of lesions like liver abscess in that location? What would you suggest them?
So early intervention should be done.
Don't wait till the pyonemothorax happens. It will complicate your situation. So in this case, in that location, you have to intervene as early as possible. So there was a delay in intervention because of the diagnostic financial constraint. We are losing dilemma is purely your liver abscess or something else like growing teratoma syndrome. We don't know it. Now, patient को पाइरहेको छ now coming to the patient भन्छौ साधन तिमीलाई के लाग्छ so far यसमा hepatic how common it is the hepatic primary yolk sac tumor it's very uncommon it's very uncommon. I think very few cases would have been reported, so we don't know how it has to be approached, but I think in general as we approach to the other germ cell tumor we approach the same way germ cell tumor. So अब यसमा के छ भने now there is the bile secretion from the gestated. What would be approach? Will wait and watch or do something else? What would you suggest now? के गर्ने पेशेन्टलाई?
We can wait and watch, and if it does not stop on its own, then it may need surgical intervention for. We can tie those bile ducts.
So you are thinking that to re-intervene, go into the cavity and find out the bile left and do something else. Devandagari, I think this is one of the options. First, request the patient to bring the old files. He is on the way to bring the old files. We don't know. We record the and check पहिला साँच्चै के त्यही लोकेसन थियो कि थिएन. If त्यही लोकेसन थिएन भने we might think about the liver abscess only rather than you growing teratoma syndrome. Let's suppose he had got 2 situations. One situation you said the liver abscess is there. Then you go for the ligation or something else. Dr. Sagar, he is expert in the liver side.
People will try to do endoscopic management because it is already liver abscess with diaphragmatic adhesion is very hard. Very difficult to dissect. And out the cystobiliary communication or whatever the biliary communication with the site. So endoscopy sterotomy will be the best option, or you can go for ERCP stenting also. And if it still doesn't resolve, then you can consider for surgical intervention. And if it is deteriorating, then you will consider for surgical operation. And you have to do the milk test or saline instillation test. You will do cholecystectomy first. Cystic duct would be cannulated by the tube, and you have to inject about 10 ml or 20 ml of propofol. But distal clamping, by the distal clamping of the common hepatic duct or CBD, CBD should be done with bulldog clamp, and you have to inject it. And you will see the instilled propofol will be coming out. We don't use other kind of dyes. We usually prefer propofol because it will be easily visible, as well as it is going to be absorbed very quickly, and it is non-toxic to the liver. So we'll instill, and milk test would be done, and you'll confirm the opening, and you have to do for surgery. Second option. Third option is because this patient is already having the risk of malignancy, right? That this patient may have got primary, could be the junction tumor of the liver, and you can consider if the patient is very good, then you can consider for liver resection also in this case. But while performing liver resection, it's very difficult. It is going to be very difficult. You have to go for anterior approach, side going for posterior approach. If you are going to refill the liver towards other side, you will get IVC or a rat. It will be torrential bleeding, and patient may collapse or die. It will be very difficult. So you have to go for hanging manual liver resection. It's proposed by Belgit and such scenarios. Or any kind of biliary fistula, you don't go for posterior approach. You should always try for hanging manual interface. You will have to tunnel the interface between liver and IVC, and you have to do anterior hanging maneuver. You have to do anterior resection first of all, then only you will impart to other parts. So that's how you have to go, like the pyramids.
So one thing, he said very important message in how to approach. So my thinking is that we consider otherwise, since it's a high risk group patient, the location of tumor is not very favorable, it's very big, and the bile is coming. So I would suggest that what he said is for the first time in the beginning, that we go for the ERC wellness treatment, followed by, in such cases we think not the liver abscess, that something else like tumor. So I think one of the options could be the hepatic artery embolization of that part, so that the shrinkage somehow of the tumor blood supply. Sometimes what happens, any tumor of the liver would shrink after the hepatic artery embolization. So since it is located in the right lobe of the liver, right? So we can do the right hepatic artery embolization, and then definitely, since it's the growing teratoma syndrome, this is the indication for the surgery. Then in the second setting, we can take the patient for the right hepatectomy. So that could be the win-win situation for this patient. त्यो मलाई लाग्छ यसको लागि हामीले प्लान के गरौँ, पहिला रिभ्यू गर्ने, त्यसपछि हेर्ने. अब हामी केही चिजहरू चाहिँ डाक्टर साजनलाई पनि सोध्न चाहन्छौँ. So such patient, kindly please give us some important messages, because such patients may have them come again and again in the future. Young patient, retroperitoneal location, tested normal. Now, because of financial constraints, you're thinking of the growing teratoma syndrome because of the tumor markers of normal. Do you think something else?
Sorry, in my view, I think the growing teratoma syndrome is the most appropriate diagnosis in our case. If the tumor marker, alpha fetoprotein, and every other finding of the yolk sac tumor pathology is normal, then for growing teratoma syndrome, sir, have we taken a biopsy from the CCD?
Because only the cytology of the tumor, because there is only cystic lesion, the radiologist report no solid component.
Then, since the patient is financially deprived, so I guess he cannot go for PET CT. That would have given us more valuable information, sir.
Do you think in the growing teratoma syndrome PET will be avid?
So the PET will not. It won't be avid, sir. If it is avid, then we could think of other pathologies, sir.
Because since it's already AFP tumor markers are normal, so I think personally that there will be some natural teratomas or something like that. So
yes.
It will be
not avid. It will be also avid, no?
Anyway, it's one of those we can think
yes.
of the patient party.
Yes.
That's it, sir.
Whatever in such cases, surgery is the most important.
Yes, sir. Surgery is the one treatment option left behind.
Various surgery. Comments or questions within your left. First, we collect as early as possible this older reports, record to see and keep the answer. Let's suppose earlier TNL when they think of simply liver abscess, and we plan accordingly and wait for conservative management. If it doesn't resolve, then we'll go for the surgical approach as specified of starter. When I look at ERCP and stitching learning doesn't resolve, then go for the hepatic artery embolization, etc. Maybe it's simply liver abscess, then it can resolve spontaneously. Maybe in complication time, it doesn't matter. There were early world report of collect world report collect message key message since it is on tumor non-similar matters. Biopsy is not always necessary. You can diagnose on the basis of tumor markers. Difficult location of the tumor, sir. Then the tumor biopsy they are prove essential right now. Like say under tumor markers rest so many prove gonna so your case retroperitoneal should be raised. General guideline 20 is also increased level. But less than 20 we don't consider. It may happen in certain other scenarios also. Given the body is suspect, higher than the classification tumor markers for S classification gain various ANCC, the TNM classification. उसको level है सर अगर between beta S is a इसको त्यो level वाला से उसको उन stage था पाऊँ definitely twice stage 3 patient. So in such cases, test is normal. We start with the chemotherapy. The generally combination 4 cycles of PP. Then we check for the tumor markers again. If the tumor markers are regressed, and still the disease is there, whatever non-cellular matters in the retroperitoneal, we go for surgery. We go for the RPLM, retroperitoneal dissection. Thankfully, tomorrow we have the case of another case of the child in whom we are going to perform the retroperitoneal lymph dissection. Similar case, there was site testicular tumor. Then the retroperitoneal lymph node after chemotherapy, there is the persistent disease, the retroperitoneal. Simply, you will be having a chance to observe the retroperitoneal dissection in another case. So we are just like you going to each time complete response when you just observe the patient. 3 monthly, 4 monthly, do the tumor marks are very sensitive in such cases. So message stay clear. But if there is the increasing in size, so how do we define the growing teratoma syndrome? Is first, tumor marker should be normal. So there is the tumor which is growing in size. Grow garcha, but markers are normal. Confused was like you. So you have and that will after surgery definitely that will show the mature teratoma. Teratoma नै देखाउँछ तिनीहरुलाई पनि this is the confirmative diagnosis. This is the growing teratoma syndrome of the living. So यसलाई सर्जरी गर्नुपर्छ किनभने त्यो पेशेन्टलाई growing teratoma they are not sensitive to the chemotherapy, they are not sensitive to the radiotherapy. They have got the increasing size that will cause the compressive symptoms and they will surgery गर्न essential हुन्छ. यदि भन्ने हामी फेरि यो पेशेन्टको बारेमा भिजिट गरौँला. Dr. Sunil सरलाई भन्न चाहन्छु हामी यहाँ छौं हजुरको रेजिडेन्ट यहाँ हुनुहुन्छ. Dr. Sabun, he presented very well under your supervision. We definitely हामी बिलिभ गर्छौं कि स्टुडेन्ट पनि राम्रो हुन्छ. पहिचान गर्न पाए चिन्न पाए Dr. Sabunलाई he did very well. Message.
MCH को पनि इक्विभ्यालेन्स पनि भयो NBMSS मा.
Sunil सरलाई पनि congratulations if you looking at us.